Hello, welcome to case-based learning of cardiac MRI on mricardiac.com. Middle-aged male presented with breathlessness on exertion. 2D echocardiography was abnormal and hence cardiac MRI was suggested for further workup. So these are 2-chamber, 4-chamber cine images which reveal presence of this hypertrabeculated myocardium, especially in the apical and lateral wall. Short axis images again confirms the same findings, hypertrabeculated or spongiform myocardium, which is predominantly seen in the apex and the lateral wall. So these features are suggestive of LV non-compaction cardiomyopathy. The diagnostic criteria is to be measured in end diastole, and whenever there is ratio of non-compacted to compacted myocardium measures more than 2.3, it is considered diagnostic of non-compaction cardiomyopathy. Make sure that you use end diastolic measurements on SSFP images, either short axis or long axis, but myocardium has to be perpendicular to the plane of measurement. The other diagnostic criteria which may be helpful is calculation of non-compacted myocardial mass, and whenever it is more than 20% of the total mass, it is considered abnormal. Usually there is no evidence of late gadolinium enhancement, but sometimes gadolinium can be trapped in this deep intertrabecular recesses. Make sure not to mistake it as abnormal LGE. Since it is primarily a muscle abnormality, there will be elevated values on T1 mapping because of fibrosis. So LV non-compaction cardiomyopathy, it is very rare disease. It occurs because of premature arrest in early cardiac embryogenesis. There will be persistence of spongy layer of myocardium in certain ventricular region, especially in the apical region and the lateral wall. Classical features are prominent trabeculae with deep intertrabecular recesses. There will be continuation of LV cavity with this deep recesses and no communication with this epicardial coronary system. It can either occur as a single LV non-compaction cardiomyopathy, but it is usually a continuum of other genetic cardiomyopathy, such as dilated cardiomyopathy and hypertrophic cardiomyopathy. It is genetically heterogeneous disorder and clinically presents as classic triad of heart failure, arrhythmia, and thromboembolism. The management varies depending on the symptoms. Most importantly, we should take care not to overdiagnose it, because many diseases will also have prominent trabeculations. So the exact diagnostic criteria on 2D echocardiography and MR has to be taken into consideration before labeling it as LV non-compaction cardiomyopathy. On 2D echocardiography, the measurements are taken in systole, and whenever the ratio of compacted to non-compacted layers, so this ratio NC upon C, whenever it is more than 2:1, it is considered abnormal. This again has to be taken in absence of any other cardiac abnormality, especially after ruling out dilated cardiomyopathy. Cardiac MRI criteria developed by Peterson et al. As discussed earlier, ratio of NC upon C more than 2.3 in diastole is considered abnormal, and Jacquer et al. Had formulated another criteria when trabeculated LV mass is more than 20% of the total mass, it is considered diagnostic of LV non-compaction cardiomyopathy. Similar concepts can also be found in our book, Cardiac MRI Simplified. For any feedback and suggestion, please mail us on info@mricardiac.com. Thank you.